Welcome everyone. Today I will be presenting a lecture on the book we are writing, The Essentials of Diagnostic Decision Making. The most critical and difficult part of the book is to understand the statistical explanation of diagnostic decision making rules. So I thought it will be a good idea to present a 1-hour lecture on this area, so that you can better understand the content of the book. The whole book focuses primarily on how to close the gap between expert and novice and provide recommendation to become an expert. The book content and other features can be seen as theeddm.com. And again, this is Azad Kabir. I'm a hospitalist at St. Mary's Hospital at Evansville, Indiana. Today we'll discuss the diagnostic decision-making rule based on statistical point of view. And also we'll discuss interpretation of diagnostic test results from statistical point of view. And also we'll discuss implication of statistical number in patient care. Before starting the lecture, I believe it is very important to define what is practice of medicine is. Until to date, the practice of medicine is an art. It is not a science. What I mean by that is, as art allows everybody to incorporate their own flavors, practice of medicine to a certain extent provides the individual physician to incorporate his or her own ideas to take care of the patient. What we see when we in the residency training or in fellowship training, where the clinical decision making is taught, is who is saying is more important than what is being said. By saying that, I mean is, if a attending physician tells you something when in training, when you are learning diagnostic reasoning, is kind of Bible. You have to do it. And the culture of medicine or teaching and learning of medicine in 100 years didn't change. So my question always is, why such an autocratic system exists in an era of science and technology? This lecture will try to explain how does this art, and then instead being an art, how can we incorporate the science in our daily clinical practice. The reason, there are a couple of reasons why practice of medicine is an art. One of them is clinician makes decision in the face of uncertainty. Almost all the time when we have to start treatment for certain medical problem, as a clinician, most of the time we don't know actually for sure with 100% certainty what is the diagnosis. But despite not knowing it, we have to initiate a treatment. And as normal human behavior or phenomena, we deny the existence of uncertainty, and this denial is being replaced by confidence or certainty. Another point is, physician deals with individual subject. Here sample size is 1, rather than a group of people. This makes a big difference in interpretation or implication of any research finding in individual patient care. I will discuss this in further slides. In contrary, when we want to say any science should be or have to be, any theory should be proved or disproved by a reasonable manner in terms of mathematics or statistics or some other process. In this test, statistics fits the criteria. It is a science. Its more focuses on what is being said. Who is not important. In contrary, medicine depends on who is saying it. If you look at any conclusion for any research paper, you will find it that conclusion includes may, might, can, could. That means research findings are always uncertain to a certain extent, and statistics itself does not confirm or deny an association. It only suggests. Most important part is conclusions we made from a research are good for a group of subjects, not for an individual subject or patient. So I will also discuss this in future slides. This is one of the most important reasons why the medicine has the ability to adapt, practice of medicine has the ability to adapt individual preference. Let's start talking about a diagnosis. And I will start talking about a controversial case where two specialists differ about the diagnosis in a patient. This case was been published in article written by Sonnenberg. So here is the case. Patient with a chief complaint of non-bloody profuse diarrhea. Presented to the hospital, and 2 weeks before his current visit, patient completed a course of antibiotic for UTI. On presentation, patient had a fever of 38.6, has diffuse abdominal pain and abdominal tenderness. Patient also has an elevated white count of 10.4, an ultrasound of the abdomen and a CT of the abdomen both reveal thickening of the colonic wall in the area of cecum with periodic accumulation of ascitic fluid. The stool test for C. diff toxin was negative. He was empirically started on flagyl. His diarrhea improved but did not resolve completely. The negative stool test and the moderate response to metronidazole made the attending or primary care physician think that this patient has appendicitis. In contrary, the GI attending on the consult service argued that patient may have C. diff colitis. So now this is a real-time problem in a patient where we need a decision which way to proceed. And right now I have to know what is the diagnosis. And here is two differential, two attending claiming patient has two different disease, and the management of these two different diseases is completely different. So only one way we can solve this clinical scenario with 100% certainty is if we open up the abdomen and look at the appendix, which is not realistic because it doesn't serve my patient. So only another possible non-invasive way of finding this diagnosis is by calculating statistical probability. So the only possible method we can calculate a statistical probability and then find a reasonable diagnosis is via Bayes' theorem. You can see at the bottom of the slide the equation I wrote, and it's written in the bold that you do not have to remember the equation. Also, you do not have to understand the equation. You just have to see the component, what is in there. There are a couple of research that actually made this non-realistic in to use Bayes' theorem in clinical practice. But using Bayes' principle is the only way we can inject science in the practice of medicine. So I will be focusing on this Bayes' theorem in this lecture. If you look at numerator, which is here P, and P, this P, pre means pretest probability, and then next is sensitivity, and if you look at the bottom, you have also specificity. These are the only three components in that gives you post-test probability in the Bayes theorem. So we have to learn three terminologies: pretest probability, sensitivity, and specificity. This post-test probability means disease probability. Let's talk about pretest probability. This pretest probability is usually calculated from the disease prevalence, and it is very difficult to remember a lot of time, but you can have a ballpark if you have a long-term experience in clinical practice, and then you will know what is the prevalence in your population. So there is two ways to calculate pretest probability. One, you can look up the resource, or you can have it from your own clinical experience. Both is permeable in Bayes' theorem. So what is the use of this pretest probability in clinical practice? Actually, we all use it knowingly or unknowingly everyday clinical practice. Let me explain how. So when a patient present to you, a 45-year-old male present to you with atypical chest pain, what do? You order a stress test to rule out MI. Why? Because you calculate a pretest probability for a 45-year-old male with atypical chest pain is 45%. This is published data. That means 45 out of 100 of them at the age of 45, if they come with atypical chest pain, they may have coronary artery disease, but rest of them, 55 of them, will not have it. Is it high enough probability for you to go ahead and do a cardiac cath versus do some other test, or ignore that? So you need to gather more data, further risk stratify the patient before going for a invasive test. The invasive test here is a cardiac cath, and cardiac cath has a lot of complication. It has a contrast, it has during cardiac complication. So you do not want to do a test if you are not sure test will be positive or not. So the main idea of diagnostic excellence is when you order a test, you are anticipating this test is becoming positive. So here cardiac cath probably is not a good idea, is because his pretest probability is low. So you want to order a stress test which will make the post-test probability, if it is positive, around 80 or 85%. At that moment, still you are uncertain. 80% is not good enough to start treating the patient for coronary artery disease. Maybe you want to further improve the probability of disease by doing a cardiac cath. So we do this daily basis. When a patient comes with any clinical problem, we do not just jump to the last test or most invasive test. We work it up and we further risk stratify and then go for invasive testing. This is actually in the background here pretest probability is working. Another time we do calculate a pretest probability is when we estimate the post-operative cardiovascular risk. So we get consults for pre-operative risk assessment. What does it tell you is, suppose the same patient, 45-year-old guy, with coming to you for a very high risk procedure, and you decided this patient has a post-operative cardiovascular risk of, for say, high risk. Okay. Now, how does it help you? What does it mean? What does it mean for future patient management or to your patient. So when you say high risk, actually, for example, high risk, you consider high risk at around 80 or 85% risk of cardiovascular complication after surgery. This is changing your now pretest probability. Same age guy who is 45-year-old, now he has a pretest probability of 85%. And the same guy now postoperatively, if he complains of chest pain, you are not ordering a stress test, because stress test will not improve your post-test probability from will improve only to 80 to 85 or keep it at around 85, because stress test itself has a low sensitivity and specificity. So you have to order a test that has a higher sensitivity and specificity, that is a cardiac cath, to confirm the diagnosis. So pre-test probability we are using every day for test ordering, and we are knowingly or unknowingly using this technique daily basis. Now talk about sensitivity and specificity. You do not, once again, you do not have to remember the equation. If you look at this is the equation how to calculate sensitivity. And sensitivity, I remember it like that. Sen has N, and usually most confusing difference between sensitivity and specificity is in the denominator they have, one has Fn false negative, another has Fp false positive. Interestingly, this was in my board, so you may have to remember it for your board, but not for the book. If you look at this red column where disease absent, say disease absent, this whole column is needed to calculate specificity. That means you need true negative divided by true negative plus false positive to calculate a specificity. Again, this blue column is needed to calculate sensitivity. You need true positive divided by true positive plus false negative to calculate a sensitivity. The another way to remember what sensitivity is other name of sensitivity is true positive rate, and another name of specificity is true negative rate. Maybe sometime it may help you just to understand the terminology better. When you say sensitivity of a test is 85%, that means the true positive rate for this test is 85%. This is the another slide why we need to know or understand the terminology. In ideal world, which is the upper graph, and this is delivered by gold standard test. How many gold standard tests we have? So far I know a couple of them: cardiac cath, pulmonary angiogram, and most likely biopsy, tissue biopsy. And we don't have many gold standard tests for clinical practice. So a gold standard test divides two group of people exactly without any spillover. So what I mean by it is here line A is dividing the group without disease from the with disease. Exactly in the middle, when they divide it, there will be no spillover in either side. But most of the test does not, cannot, or do not view the disease population exactly the way gold standard test does. The way most of the test views the population group with disease is they overlaps. They cannot, if you see this is without disease group of population, this is with disease group of population, they overlap. And whatever cutoff point you choose, suppose you choose a cutoff point of B here, and the group of people belonging to this right hand side of this upper bell curve is defined here as with disease. But in fact, look at that, this group of people belongs to without disease group. So that makes them false positive. Same way, this group of people on the bottom curve becomes false negative, whatever line you choose. So when this does, that means when your test says that patient has the disease, actually in reality patient does not have the disease in certain group of people, and you don't know which patient does not have the disease and which one have it. What is the condition of your patient? When test says CT scan negative for PE, it is possible that this is false negative. In fact, this patient probably have the disease, and the patient you are treating right at this moment. So this is another example where I am showing that you all use bias theorem in clinical practice daily basis unknowingly. When you order a VQ scan, and if you have a lung scan probability, for example, low, and your pretest probability, clinical probability is very high. So high means patient is tachypneic, suppose tachycardic, patient is having shortness of breath, patient is having respiratory alkalosis, and patient lungs very much clear. And now you think, this patient also just post-op hip fracture, I was lying in the bed, and your pretest probability for PE is very high, but you couldn't do a CT angiogram because of renal failure. Now you got a VQ scan and your lung probability is low. Look at what it is saying is, even though your lung probability is low, if you have a high clinical probability, your post-test probability includes 1. That means you may have to end up treating the patient. And look at this probability changes. If your pretest probability is low, it kind of rolls out. Say, okay, I'm not considering PE as a diagnosis here. So this is the clinical decision you make every day to treat lots of your patient. So background rule is bias theorem here. Now go back to the case we discussed in the beginning. This is the table that includes all the sensitivity and specificity for all the signs and symptoms and test results we have discussed. Unfortunately, for real-time clinical practice, we do not have the sensitivity and specificity data for all the signs and symptoms. If we have those data, a computer does the job for us. Since it is not there, it needs a human being to process this data. Now go back. You do not have to remember your sensitivity and specificity data to come up with a conclusion. And I will ask you to remember one thing from this slide. Look at the ignored. How many signs and symptoms are ignored here? 1, 2, 3. To come up with a diagnosis of appendicitis. And this side, how many signs and symptoms are ignored here? 1, which is negative for C. diff colitis. So when C. diff colitis, C. diff toxin is negative, you cannot incorporate this data to find a diagnosis of C. diff colitis, right? So you have total number of 1 sign symptoms ignored here. On the left hand side, you have watery diarrhea. This doesn't go with appendicitis, right? You have history of antibiotic therapy and response to metronidazole. None of these 3 signs and symptoms or history piece does not go with appendicitis, so they are ignored here. So here is 3, here is 1. And the same author I mentioned before, actually plotted all of these data and came up with a diagnosis. If you look at the bottom, that came up with a appendicitis probability is 7%, and C. diff colitis probability is 94%. Now, where do we go from here? I will discuss the implication of 7% throughout the lecture as well as 94%. But from this slide, at least we get a working diagnosis that most likely my patient has C. diff colitis. It is not 100%. So if it is 100%, then probably I will be confident with absolute certainty. But here, since it is 94% and is much higher than 7%, I can be reasonably certain, say, okay, this is my working diagnosis. One more thing to say from this slide is this 7%, with the exact presentation, with all the signs symptoms has this patient, 7 out of 100 patients can still have appendicitis. So how do you incorporate this data in your daily clinical practice? We'll discuss that also. Now, one more rules we all use during clinical decision making is Occam razor. If I say it, I will read it aloud. If multiple competing theories are used to explain a fixed set of given facts, the theory using the least number of assumptions is given the highest credence. I know lots of you know Occam razor, but one most common misconception is Occam razor advocates for a least number of assumptions, not one assumption. So you should be trying hard to find a least number. Least number can be 2, least number can be 1. If you have a 3 diagnosis that explain all the signs of symptoms of your patient, try hard to make it a 2. If you can't, be happy with 3. This Occam razor emphasizes on finding the least number of diagnoses. Also, it emphasizes on each and every finding. Either it is positive or it is a negative finding. When you come up with your final diagnosis, your final diagnosis should explain the positive finding as well as negative finding. Now let's 2 or 3 slides before I told you to remember the ignored signs and symptoms. In this slide, we will come up with a rule where you do not have to calculate Bayes' theorem, but come to a conclusion as if Bayes' theorem was been done. So your conclusion without using Bayes' theorem, you can replace Bayes' theorem just by calculating. If you just add up the total number of signs and symptoms that remain unexplained by each of the differential diagnoses, then choose the differential diagnosis that has the least number of leftovers. Let's go back to the slide. So this slide has total of, in the left hand side, there is a total of 3 signs and symptoms ignored, and there is only 1 which has a least number of leftover signs and symptoms is in this column, which is for C. diff colitis. Also, Bayes' theorem came up with a conclusion that this patient has C. diff colitis, 94% probability. So almost we can replace Bayes' theorem by this clinical decision rule. Now I have a question for you. Question is, what if you did not explore all the available signs and symptoms your patient has, and then you are calculating ignored signs and symptoms based on incomplete history? So how do you overcome this problem? I will discuss this in diagnostic error prevention slides. One more very important concept from Bayes' theorem is what is the maximum probability we can get from Bayes' theorem? This is important. If you look at the Bayes theorem equation, if you see, look at that numerator, this is present in the denominator on the left part of the denominator, same as the numerator. And this is extra chunk, which includes the specificity. So this equation kind of, if you simplify, if you say this is pretest probability times sensitivity is equal to x, you can say x divided by x plus y. That means your denominator will be always higher than numerator. That means if you solve this equation 100% time, it will be less than 1. So you can never get a 100% certainty using a Bayes theorem. This is very important concept. A lot of time you will try hard, say, okay, I want 100% certainty. It's not possible. You cannot get a 100% certainty in clinical practice, period, unless you use a gold standard test. Total number of gold standard tests probably you can hand count, and most of the time you do not use them in clinical practice. Let's re-emphasize this again. Suppose you have a 99% probability of certain disease. Based on statistics, it says 1 out of 100 patients with exact signs and symptoms, the patient will not have the disease you come up with the Bayes theorem or Bayes technique. So there will be always some source of uncertainty, either small or big. This gives you one very important understanding. If you cannot reach 100% certainty, what you have to do? You have to start treatment or stop testing when you reach a reasonable level of certainty. We'll discuss this in future slide. Let's discuss about prognosis we face daily basis. This all prognosis we predict from statistical number. For example, there is 10% probability of survival with a certain treatment. Suppose it is a cancer treatment and there is 10% probability of survival. What does it mean? It means 10 out of every 100 patients you treat will survive with treatment A or X, whatever it is. What does it mean? Is it true it is 100 out of 1,000 patients? It is true, right? If you do the math, 100 divided by 1,000 is 10%. What about 100,000 out of 1 million? Is it a good number? Yes, it is. 100,000 patients out of 1 million will survive. Now, the patient sitting in front of you in your clinic desk today, will this patient belong to survival group, or this patient will not survive or will not get benefit? Nobody knows. Can it be that all the patients you see in your whole month, how many patients you can see? 20 per day, 30 days, 600 patients. All 600 patients can survive, or opposite it true, can fail the treatment. So you don't know actually with the clinical data you have with the 10% survival. Even if there are 99% certainty that the treatment will succeed, same statement holds true. The patient you are seeing you don't know will belong to 1% group or 99% group. Let's explain more. So if you have 90% risk for certain condition, what does it mean? Excuse me. First of all, this is a statistical estimate, 90%. It tells you about a group of patients, not about an individual patient. All the statistical number happens in random sequence. There is no measure to predict the sequence of events. There is nothing in literature or in science that can predict what sequence the event will happen. And if you want to, if you want 100%, you need 100% certainty to confirm what will happen to any given individual, which is not possible to attain. But how do we solve problem then? In daily clinical practice, we never have any 100% certain issues. So how do we treat our patient? Here is that's why we go for best guess. Best guess is our mean, the 90%. We assume that majority of my patient I see today will belong to 90% group. That's the honest best guess, and we rely on that, keeping in mind in the background of your head that it may not work, so that you constantly try. If there is something not going right, you have an alternative differential to handle the case. Let's further discuss, because this is a key fundamental concept or difference in medicine. Why medicine is an art, not a science? Why medicine lets every physician to use their own judgment and get away with it? So every day, or in test especially, we see this test with the math. Treatment A has 25% cure rate, and treatment B has 20% cure rate. So if you solve it, it will come right. If you have to treat 20 patients to save one life, extra life. Again, events happen randomly. You can save all of your 20 patients today if you just treat with a treatment A, or all of your patients you see today may die even if you treat with treatment A. Actually, nothing is certain here. Again, let's talk about survival issue. You frequently find 12-month survival for certain condition is 20%. This is another data we use to declare prognosis. What does this 20% survival means? It means how do you know that your patient will belong to 20% group? Is there any way you know? No. This number has a standard error. Did you incorporate that? So sometimes when you say, okay, this patient, my patient lived 2 years, how is it possible? Because this all statistical number belongs to a bell curve, and this bell curve has a standard deviation or too extreme, where your patient can belong to either left corner or right corner. I will further discuss it in future slides. That lets you adapt the difference or in a different number or different outcome. Let's talk about the last one. 1 out of every 6 U.S. In this country right now lives under poverty. So how many of us in this lecture theater lives under poverty? I believe almost all of them here live more, less than 5% bracket. It doesn't work here. Why? The statistical number, the number 1 out of 6 came from whole U.S. population. And when you want to make it as for a special group, for a single patient, it doesn't work. Now, from all the discussion I made here, I emphasized on one thing. We are not sure when we are making clinical decision. If we can never be 100% certain, then what I have to do? I have to do is always consider multiple differential diagnosis. That was the focus, that was the reason I took so much time to come and discuss over and over about clinical problem solving. So anytime you see any patient, generate at least 2 to 4 or multiple differential diagnosis. Now, when you generate differential diagnosis, make sure you rank order them. I mean, what is your number 1, what is your number 2, what is your number 3, and what is your number 4 diagnosis. How do you do those? You do those based on your age-sex distribution of disease. A 20-year-old comes with headache. Stroke is at the bottom. Migraine headache is at the top. That's the way you will be ordering the differential diagnosis. Another rule is, if you have a 4 differential diagnosis and one of them are life-threatening, 45-year-old coming with chest pain, 45-year-old male has a pretest probability of 45%. That's the for coronary artery disease. It's a low. So your number 4 or number 3 differential diagnosis here is myocardial ischemia. You have to roll out a life-threatening differential diagnosis. That's why you admit them every day. Remember, you can say, oh, I considered the differential diagnosis, but you know it was not high enough, so I sent them home and patient died at home. Remember, this patient is someone's mom, someone's dad, someone's brother, or someone's spouse. To err is human, but it does not console the patient's family when they lose their loved one. So you should and must treat your patient as if they are your loved one. What will you do for your father when he admits with certain condition? Won't you roll out most life-threatening differential diagnosis if you are considering it? Yes, you will. Then another rule is, ask yourself always, or try to roll out your most favorite differential diagnosis. Now you have a differential diagnosis of GERD causing chest pain. Try to rule it out. Go to the patient back again. Ask him what happens when he lies asleep at night, whether his chest discomfort is associated with food habit or anything else. Try to roll out your most favorite differential diagnosis always. And as I said before, if you do that technique, if you just follow this rule, you are settled on a differential diagnosis. You say this patient has a disease A, and if you always try to rule out your most favorite differential diagnosis, you will be never wrong. The way we defined in the book a diagnostic error is when you link your signs and symptoms, link the patient's signs and symptoms with a wrong diagnosis, then you commit a diagnostic error. So what is the remedy? Very simple. When you link the signs and symptoms to a diagnosis and you are confident about your diagnosis, try to roll it out. Ask yourself what is it is wrong. If you try hard, you will always come to another diagnosis that may be right. Again, try to roll it out. And you always have a working diagnosis when you treat any patient. You discharge a patient, your working diagnosis is this. Like the patient we discussed in the beginning. We had a patient with diarrhea. There was a 7% probability that patient has appendicitis. But you treated the patient with metronidazole and sent the patient home with metronidazole. Keeping in the back of your head, your working diagnosis is C. diff colitis, but if patient does not get better after 2 to 3 weeks of treatment, keep in your back of the head, it is possible that appendicitis is there. So that's the way that your mind will warn you always, and you will not commit diagnostic error. One more rules from this discussion. Since you cannot achieve 100% certainty, you have to give up at certain level. Give up when you are reasonably certain. If you cannot roll out your most favorite differential diagnosis, stop testing. At what level? you stop testing. This is individualized. Let's talk more about diagnostic test ordering. The scientific way, or we compare diagnostic test, using likelihood ratio. You do not have to remember this, but this was in my board, how to calculate a likelihood ratio. So for your board purpose, you have to remember likelihood ratio for positive test equals sensitivity divided by 1 minus specificity. So you need only two things to compare the strength of a test. So strength of a test means when you have a patient with cholelithiasis, what test to order, which one is the stronger test. If you look at that, real-time ultrasonogram has a sensitivity of 89% and specificity of 97%. And then CT scan of the abdomen has a sensitivity of 79%, specificity of 99%. So how do you just incorporate both of these numbers? You plug this in the equation and you get it. What do you do in your clinical practice? What do you do when a patient comes with, you think your differential is cholelithiasis? All of us order ultrasound of the abdomen. Why? Somebody calculated it and then told you that ultrasound is a better test than CT scan. But in the background, they calculate using likelihood ratio. That's why you have to also know sensitivity and specificity to a certain extent. You do not have to remember the equation, but you have to understand the concept. Look at the infective endocarditis. What test you order to roll out infective endocarditis? Transesophageal echocardiogram. Why? Look at the answer here. If you do transthoracic echocardiogram, you have a sensitivity for infective endocarditis 50 to 70% compared to TEE. Here is 90 to 100%. Go to the next column. For specificity for thoracic echocardiogram is 80 to 97%. Here is 95% for TEE. If you plug this number, that's why TEE is a better test to diagnose infective endocarditis. So this slide is I am showing you how do you choose which test to order when. So there is two terms in your diagnostic workup. There will be always two sessions. First session is initial workup, and then second phase is your confirmatory phase or last part. So when you have initial workup, you always order highly sensitive test to roll out. How do you remember? Snout. Remember, sensitivity to roll out snout. You order highly sensitive test at the beginning of your diagnostic workup. Why you have to roll out in the beginning? Because you have a 4 differential diagnosis. You do not want to order test for all 4 of them. You want to roll out 1 or 2 with a highly sensitive test. So what is the fundamental difference between highly sensitive test and highly specific test? Highly sensitive tests are usually non-invasive. Highly specific tests almost always very invasive. Look at that, what you do when you order highly specific test to roll in or to confirm a diagnosis. That will be at the end of your diagnostic workup. So how do you remember? SPIN, S-P-I-N, specific test, specificity to roll in. Again, no test roll out any diagnosis with 100% certainty, as we discussed before. Most common we did a CT PE protocol to roll out pulmonary angiogram. Actually, we never roll out. CT-PE protocol has a specificity of 99%. That says 1 out of every 100 patients being told PE negative can be false negative. So this, another rules here is no single test can confirm or roll out a diagnosis unless it is a gold standard test. So why we use repeated test? When we use repeated test under the rules of probability, every time we use serial testing. Remember in electricity there was a resistance you put serially. When you do serial testing, what happens to sensitivity and specificity? Your specificity goes high. Every time positive test result, every test you order, one after another, your specificity goes high. Remember what I said last slide? You order highly specific test to confirm a diagnosis. So you are looking at more and more higher specificity to confirm a diagnosis. When you order multiple tests, like patient has a chest pain, this is a test, right? Without a chest pain has a sensitivity for coronary artery disease. Patient has a troponin positive, this is also test. Patient has a positive EKG changes, this is also test. Patient has a stress test positive, this is also test. So serial testing increases your specificity. Ultimately you become conform. You say, okay, I reach a reasonable level with a higher specific test. At finishing, I would discuss some more fundamentals of statistical test in medicine practice. For example, I was talking before bell curve. Any natural number, any natural variable, for example, systolic blood pressure. What is the range for normal systolic blood pressure? Suppose 90 to 130. So this means 90 is here, 130 is here, and around 110 to 120 is in the middle. So these graphs tells you that most of the population in general population, most of the people will have a blood pressure of 110 to 120 or 100 to 120. Most of the people will be residing here. Some of the people still, though their blood pressure is 90, maybe normal, they are normal, but they will be here in the curve. And if somebody has 130, they will be here in the curve. Now the patient sitting to you, this belongs to every number we talk about in medicine. Let's come back. Suppose a hospice patient, you are sending out, you are predicting this patient will live 6 months. How does it work here? So 6 months is in the middle, and look at that, some of them will live 10 months. This curve never touches the ground actually. This is unlimited. So some can even live 3 years. This is still within your prediction. And some can live 1 month or 0 month. It's 1 days and seconds and minutes, so it can be unlimited over there. So the statistical explanation pretty robust. Actually it doesn't lie. Whenever there is a number, it is so much robust. Any explanation or any patient event can be explained by this curve. Okay, now come, this is a linear expression of the curve we showed you. Like here, if you see this is delta, this is actually standard error. So standard error to standard deviation, you have 85% of the people lives here in your population within 2 standard deviation. And within 2.6 standard deviation, you will have 95% of the population. That means if you count the frequency, all the frequency together until here, and then you will find 95% of the population. Exactly here it is. So when you say this is your standard confidence interval, and your patient can live actually 2 years, this will be also here somewhere in the bell curve. Now, let's discuss one fundamental principle. We use p-value to at a level of 0.05. Excuse me. When p-value is less than 0.05, we consider it's statistically significant. What does this p-value means? This p-value means probability of making type 1 error. So you are accepting any hypothesis, research hypothesis, if their probability of making type 1 error is less than 5%. Right? So now, if you look at what does type 1 error is, when the person is truly innocent and then this jury find him guilty, this is a serious deal. That's why there is always law is in favor of, if they cannot prove it, they always make the guilty guy go free. So when the person is innocent, the jury find the guy guilty. That's the type 1 error, equivalent to any disease, any probability. So you are accepting 5% such an event when you are saying that my significant p-value is less than 0.05. That means you are accepting wrong conclusion 5% time. That means also 1 out of 20 p-values in the research paper you are considering, you are reading right now, can be false. Right? 5% means 1 out of 20. That also means the same way, maybe the most important finding in the research paper you are considering is false. In addition to this confusion about 5% wrong, as always, research is applicable to a group of people, not to a single individual. The practice of medicine is almost always an art. This is not a science. No statistical number hold true for a single individual. One more example. This is a graph I took from New England Journal of Medicine. The upper green line is ezetimibe group. This has a 95% confidence interval here. Lower red line is niacin group, has a 95% confidence here. In this very research where they have proved ezetimibe is superior to niacin group, they have also 5% population does not belong to this 95% confidence interval. These are outside. For this group, 5% belongs here, 2.5% here, 2.5% here. For this group, 2.5% here, 2.5% here. If your patient belong to here, can your patient belong to here? If he takes ezetimibe, yes, he can. Can your patient belong to here if he takes niacin? That takes out the effect difference? Yes, he can. Excuse me. Also, is there any chance that the given p-value is wrong? Yes, there is a 3 out of 1,000 chance this p-value can be wrong. So now I come to another diagnostic decision rule from this above discussion is continue traditional treatment option if therapeutic outcome is optimum, if you are satisfied with the treatment. Unless there are repeated several studies with repeated similar finding. Do not change your practice before seeing that. what do you do? Why do you look at meta-analysis? Why don't you just rely on a clinical trial, one single clinical trial? One single clinical trial, the most important p-value can be wrong. That's why they rely on meta-analysis. Multiple clinical trial with similar finding. In conclusion of this lecture today, if you want to take home 3 points, I will say number 1, always consider multiple differential diagnosis. What you see, what is the fundamental difference between expert and novice? One of the difference is novices are always, most of the time, very confident, overconfident about their diagnosis. But if you look at expert, actually it is published over and over in the literature. In our book, we have addressed this in the first section, as I said before. If you expert learn over the years that we cannot be confident. Sometimes you find a diagnosis, you find yourself wrong. So, and also I proved during whole lecture that you can never be 100% certain. So always consider multiple differential diagnosis. Number 2, rule number 2 is try to roll out your most favorite differential diagnosis. If you try to roll out your most favorite differential diagnosis, you will be less frequently wrong. And as I said almost every single slide, one thing, you can never be 100% certain. There will be always some level of uncertainty, and the patient you are treating is someone's mother or father or spouse. To err is human, doesn't work to console them. What will you do if it is your loved one? Treat your patient as if they are your loved one. Finally, I will invite all of you guys and girls to help me build a forum on diagnostic decision making. You will find the forum on theeddm.com. Right now, with the advance of science and technology, so far we do not have a discussion forum for diagnostic decision making. Why it is important? Each and every one of you is been treated, it's been learned medicine in different hospital. Suppose there was a M&M case in your hospital, and this similar M&M case will be repeated somewhere in the world. And if you share your experience and knowledge, I can learn it from sitting here without waiting for another patient to die for the same event what you have invented and prevented. Let's share with each other, and thank you all for coming or giving your time to hear this lecture. Thank you very much.